Welcome, everybody, to the Build.well.being 2023, a digital healthcare networking event. I'm happy to see so many of you here at the St. Pölten University of Applied Sciences. I also would like to give a very warm welcome to everybody who's watching us online. I've heard that there's plenty of people who registered online and are watching the video right now. I think it's great that so many of you are here, and I already realized that the audience is rather varied, as it's always been. We have health professionals, we have developers, we have well-established companies, we have young startups, we have visionaries and next-generation innovators. It's already the seventh event, the seventh Build.well.being. It's become an annual tradition here in St. Pölten, and I think that's something to be proud of. Today's motto of the day is data-driven healthcare. And everybody of you knows that healthcare, or health in general, and data, those are two things which go together, which belong together. And this has, of course, always been the case, but it has not always been known. Actually, the idea that data and health is so closely connected that we have to scientifically integrate data into health sciences is a rather young one. We can look back about 300 years. The situation was quite different back then, and so this motto of today reminds me of a story from the 18th century about the British Navy, curiously enough. Back then, it was not a good time to be a sailor in the British Navy. Believe me, you wouldn't want to be a sailor in the British Navy in the 18th century. So lots of sailors died back then. Of course, there was a huge death toll due to sea battles against France and Spain. But the death toll of those sea battles was, interestingly enough, lower than the death toll of something else, of a disease, of scurvy. So lots and lots of sailors became tired and sick. They lost their hair, they lost their teeth. Some of them went blind, and then eventually they died. Today we know that this is a consequence of vitamin C deficiency. So if you spend a long time on a boat and don't have proper food, that's what happens. But back then in the 18th century, people didn't even know what vitamin C is, so it was kind of a mystery. And there was this one guy called James Lind. He was a doctor from Scotland in the British Navy, and he had to treat lots of patients who suffered from scurvy, and he wanted to do something about that. So he did a data-driven approach. He said, okay, let's take the sailors on my ship and divide them up into several groups and give them something additional. So some of those sailors would get, say, oranges and lemons. They were already available back then. Other sailors got maybe a glass of seawater to drink every day, and others got diluted sulfuric acid. So he was quite creative. And then he said, okay, who gets scurvy? And as you can imagine, the sailors who got to eat oranges and lemons every day, they did not get scurvy anymore. So, huge success, data-driven approach, and now we know what's going on, you would think. But unfortunately, this was not the case, because data alone is not enough. The big problem was that James Lind didn't really do anything with the data. He thought, well, okay, lemons are sour, so it has probably something to do with acid. So actually, sulfuric acid may be even better than lemons, and that didn't really work out, so it was complicated. And it was not until decades later that eating oranges and lemons really became part of the official food prescribed to sailors in the British Navy. So this story tells us that coming up with data alone is not enough. You have to integrate data. You have to think about what this data tells us. You have to connect this data with other data that's available. You have to talk to patients, perhaps, and you have to put together a big web of data which makes sense, a semantic web, if you will, that really allows you to draw conclusions. And I think that's why we're here today, to talk about how we can work with data, what artificial intelligence means for all of that, how we can think about digital tools for patient interaction, how we can use data-driven approaches to deal with data reported by the patients themselves, how we can use data approaches for workforce management, and many other topics. And so, without further ado, I would like to welcome to the stage Professor Tanja Stamm. He's a professor for outcomes research at the Medical University of Vienna and part of a huge and well-funded European project called Health Outcomes Observatory, and she's going to talk about the patient's voice in healthcare. Thank you.
Yeah? Okay, so this one. So thank you for the invitation to come here and give a keynote talk on the patient's voice in healthcare and how we can empower patients with data. And thank you very much for the nice introduction. And I have a similar story about the history. And it's again about the United Kingdom. And it shows Florence Nightingale here, and Florence Nightingale was maybe the first, she was definitely the first outcomes researcher, and I'm an outcomes researcher myself, but much later, of course, in history, and I'm from the Medical University of Vienna, from the Center of Medical Data Science and the Institute of Outcomes Research, and we have founded our institute only a few years ago. But Florence Nightingale was probably one of the first people who really tried to use the data and to collect data in a systematic manner. And she was maybe also, and I think this is very important also for the University of Applied Sciences here, she was maybe also the first nursing scientist in history. What does this? And this is the famous chart that Florence Nightingale has produced. And she also looked into soldiers. Yeah? And her aim was to find out why the people died. And what you can see in this chart here, and what she did, maybe in difference to the story that you told before, she visualized the data in a very good way. Yeah? And what you can see here on the chart is you see the causes of the death. And the red area is the death because of the wounds of the soldiers. The black area is any other kind of reason, and the blue area is the death because of infections, yeah? Of diseases, of communicable diseases that the patients get in the hospitals, in the lazarettes, after they have been wounded. And what you can see is that the death from these communicable diseases is much higher than from the wounds. Yeah? And Florence Nightingale used this data, and the chart is still very famous. Yeah? It's one of the first charts that actually showed data in that way, and that made it very intuitive what you can interpret. And she went everywhere. Yeah? She went to all these male doctors and politicians and people in the army, and she convinced them that it's about hygiene and better food for the soldiers, better hygiene would prevent all these deaths. And that was really a big achievement, I think. When we go from the history to the future, what are the biggest challenges in healthcare in the future? What will this be? And if we look into the high-income countries, yeah, the biggest challenge will probably be the sustainability. And this is really for countries with high GDP. Yeah? And that means that healthcare in the future will simply be too expensive. Yeah? So we need all these different digital tools, probably, all the innovative ideas and everything to prevent the healthcare system from collapsing, because it will become too expensive in the future. What we need is, we need more resilience. We, of course, have to face all these social and societal mega trends like digitalization, and I think that's exactly the people who we would meet here at this type of conferences, who develop all these smart and important tools in the area of digitalization. We have a different workforce, so the people who will work in 20 or 10 years will probably work less. They will work longer in their lives than we do, yeah? But they will be more focused also on health promotion probably, and also on other types of activities and not only work, yeah, like we did maybe in our generation. We have an increased life expectancy, of course, and that's also caused by better healthcare. And patients are challenging healthcare more than they did years ago. And I think patients really want to have shared decisions. They want to have a different relationship with their healthcare provider than it has been 20 years ago. We are still facing inequity, and especially, and I think when we look into technology, like we do this here on this conference, lots of people do not have enough digital literacy. They do not have access to technologies. Yeah? So we have to take that in mind, that we also lose some people when we move healthcare a lot into the digital world. We are facing everywhere staff shortages, especially in the nursing sector, but in all the areas in healthcare, and this will be also a future challenge, especially maybe in some countries, but probably maybe in really all areas in healthcare. And what we also see in a lot of the survey research we do, we have a lot of mistrust in science. And we see that a lot after the pandemic now, that people do not trust scientists and have a lot of mistrust in institutions. And we saw that lots of people are very skeptical towards innovations that come from science. Yeah? So what do we need? We need a lean and value-based healthcare system. What does that mean? That means that we put the patient value into the center, and like you introduced in the beginning, we probably also need to get data from the patients. We need to ask the patients how they are, how the outcomes are from their perspective, and whether the situation has improved after a certain treatment or disease. We are focusing, or we're seeing more and more outcomes-based payments, so that would mean shared models where the industry, the manufacturers of the drugs, and that applies especially to expensive drugs in rare diseases, where the industry shares a risk. So if the patient doesn't respond to the drug, then the social care, the healthcare payers would not pay for it, but the industry would also share some of these risks. And here we talk about drugs for rare diseases, which cost about 200,000 or 300,000 euros per year per patient. Yeah? So that's something what we will need in the future, and especially when we look into these gene therapies. We need more interdisciplinarity and diversity, and I think that is probably also something what you showed before with the master courses here that are really addressing people from the different disciplines. And we need data that should be linkable, they should be big, they should be on time. Yeah? So time to analysis is something which is probably very important, and that can depend really in intensive care units where data after 10 minutes would be old already, to analysis where we consider much older data. But essentially, I think the time to analysis is really important. In hospitals, we have a ratio where we measure quality of the acute care, and that's the time to needle. Yeah? So that means the time until a patient who enters the hospital has a needle in his or her arm. Yeah? So, and how long they have to wait, and these kind of things when they have something very acute. Yeah? And I think for data, it's probably similar. Time to analysis is maybe critical in the future. It needs to be secure, it needs to be accessible and democratic. And I think when we ask patients to collect data, it will be also important that we give them something back, we give them some feedback, but we also give them some access to their data, so that they can also use the data for self-management and for interaction with their healthcare providers. Yeah? Important is who will analyze the data. So clinicians, for example, are very concerned with the European Health Data Space. The data will be analyzed by a group of data scientists who have no idea about healthcare. Yeah? That's maybe a little bit exaggerated, but I think we need all the different perspectives and really some interdisciplinarity when we analyze and make conclusions and draw conclusions from the data. Otherwise, we will maybe give the soldiers not the oranges and the nice fruits with the vitamin C, but other things, because we draw the wrong conclusions. Yeah? So is data-driven healthcare really a solution, and should data, how can they be useful also for the general public? And what we do in one of our EU projects, and that's called Health Outcomes Observatory, H2O. We want to give patients, we want to collect patient-reported data, but give patients also the possibility to use this data for better health care. And patient-reported outcomes are in the main center of the project. They are really important to improve the dialogue between patients and clinicians, but also for researchers, for scientists who can use the data to validate algorithms, for example, and I'm sure we will hear more about that in the second keynote, and also for the healthcare providers who can do benchmarking and see whether they would be better than other hospitals, for example, based on this outcome data. What do we need first? We first need to standardize what we want to measure, and for this there are several organizations internationally, and what is really important, and you see here an example from the ICHOM set in breast cancer, and you see that there is a lot of patient-reported outcomes included, and what ICHOM does in this process is that they do not only ask the healthcare experts, but the patients themselves. So in all of these groups, you will find patients who co-decide what should be measured from their perspective. And we do exactly that also in our Health Outcomes Observatory project. This is a public-private partnership. It's funded through IMI. It was called before, it's called IHI now, Innovative Health Initiative. And it's together with the pharma industry. The pharma industry provides in-kind contribution, and the public consortium gets the EU grant. And the idea is to build up an infrastructure where the patients can collect their data, and we will do that in 4 European countries and have selected 3 disease areas, namely diabetes, inflammatory bowel diseases, and cancer. And we will give patients tools to collect the outcomes. Apps, for example, we will not develop a new technology, but create an open ecosystem so that patients could basically use any type of app that would fulfill our standards here in H2O. And patients can then collect their data, and healthcare providers would see them in a dashboard, for example, and can then also use this data to decide what kind of treatment or what the patient might need. We will run prediction models on the data, and important is that we will not only collect patient-reported outcome data, but connect them to the clinical data from the EHRs, from the electronic health records. Yeah? I have a short video here. Let's see if that works. Yeah.
Like water, health data is an essential resource. It should be accessible to all stakeholders with a legitimate interest, including patients. It has the potential to inform and facilitate better conversations between patients and their healthcare providers. The result is better care for individuals and more efficient and sustainable healthcare systems for the entire community. At this time, there are only very few examples of systematically measured patient-reported outcomes being used in individual clinical care. No widespread approaches exist to address this shortcoming at scale. 23 world-leading institutions, including university hospitals, patient organizations, and industry partners, are joining together to design the healthcare infrastructure of the future. The H2O project is the first ever attempt to collect and incorporate patient-reported outcomes into healthcare decision-making at an individual and population level across multiple locations in Europe. Within 2 years, H2O will set up independent observatories in Austria, Germany, the Netherlands, and Spain, as well as a European umbrella observatory. The observatories will have an initial focus on diabetes, inflammatory bowel disease, and cancer. H2O is being established such that it's capable of scaling up to more countries and more diseases in the future. Health Outcomes Observatory, making health data as an essential resource, available to all.
Yes, what is maybe very important is that it should be really like an open ecosystem for SMEs for other tools that will be developed in the future to connect really, and the idea is to collect the data from the patients, but also to develop a governance model like what was shown in the video, that data would be accessible also to the private side for validation of algorithms, for example, and accessible means, of course, in a safe environment under certain conditions, and maybe also some of the stakeholders getting only aggregated data. Yeah? But I think that's really something what is missing at the moment, because a lot of, especially from the digital sector also, startup companies have difficulties accessing health data for validating the algorithms. Yeah? And there's much more data available in the United States, for example, but much less in Europe. And Europe has a much more fragmented outcomes landscape also. But if we validate all the algorithms only on data that are not from our populations, it's difficult to say whether they actually work also for our patients. Yeah? What is planned now? So we are going to run a feasibility study on this, and including our first patients. And we have also some kind of maturity model developed where we will assess whether a country does fulfill what we want here. So that would really mean the outcomes data collection, but also the possibility to implement the governance model and share the data. And the idea is to have something like a certificate for H2O implementation tested, because we will not want to develop new outcome sets or new apps, but just look into whether it's implementable and usable in clinical practice. And for that, we need especially the clinical experts also who will test this together with us. Yeah? And I thought that it would be very interesting maybe to share also some data here about the patient perspective to data sharing, because I think that's very important, and I think it's very important to the patients, and I think we will hear maybe in the panel also a little bit later more also from the patient side. And we have recently published in Nature Medicine a paper on the determinants of COVID-19 vaccine fatigue. So we have actually asked a representative sample in Austria and in Italy about their willingness to do a COVID-19 booster vaccination, and that was last summer, yeah, before autumn, where we wanted to do all these booster vaccinations. The question is how this will develop in the future, but maybe it will be something like the influenza vaccination, and you will have a combined COVID and influenza vaccination in the future. Yeah? So the idea was to ask patients about their willingness to vaccinate, and in this study we also run another experiment, because what we have done here, we have tested different incentives. Yeah? So what kind of incentives would convince the people, yeah, the citizens, to go for a booster vaccination? And we have done an experiment, a conjoint experiment here, and in such an experiment you randomize the different incentives, and patients will see scenarios. So they will always get two scenarios which they will see, and it looks like this, and it's of course in German. It's in German and Italian, because we run it in German and in Austria and in Italy. And people will always see two scenarios, and they can then decide which of the scenarios applies more to them, or in which of the scenarios they would be more willing to be booster vaccinated, for example. And what we also ask them here is under which conditions they would agree to sharing their health data. Yeah? And we have we had two scenarios again, and we asked the patient which of the scenarios it would be more likely that they would agree that their health data could be shared with research, and research was in a broader sense the public and the private side. Yeah? And we have surveyed a real big number here from Austria and Italy, and it was done last summer. And we've also asked about trust in institutions. We have asked about trust in science. We have asked about the emotional states because of all this crisis that happen at the moment and people are experiencing. So we wanted to have a little bit more data also about the patients. And what you can see in this experiment is that patient would then benefit or would agree to share their data if they benefit from the data usage themselves. Yeah? So we told them, for example, that if you would have cancer and health data would be shared, an algorithm could be developed, and you could get a better treatment in the future, or other patients could get that. Yeah? So if people have the feeling that they would benefit from data usage so that the data would be really, or that the analysis of the data would benefit them, they would agree to the data sharing. Also, access for the private side is seen in Austria especially a little bit more critical than in Italy, and the red bars here on the red lines on that you see in this chart here, and it's just really a very preliminary analysis because I have done this only a few weeks ago, so it's really the first data of this experiment. The red ones are the Austrians and the blue ones are the Italians. Yeah? And you see that especially in Austria, the people are very skeptical. That's why the red line here is on the left side, a little bit further down than the blue line. Yeah? So the people are very skeptical sharing data with the industry or with the private side. But in Italy, this is not the case. Yeah? Financial things do convince more in Italy than in Austria. So if people would, or if we would pay the patients for their data, that would convince more the Italians than the Austrians. And people would want to agree, yeah? So they do not want their data to be used without consent, yeah? That's also important because, of course, secondary data could be used without consent at the moment, and we have to have an ethics application, of course, and go through the ethics committee, but we could use secondary health data without patient consent. But especially in this experiment, we see that people would like to consent to the data. Yeah? If we talk about sharing of data from patients, I think it's important to mention an initiative that was launched at the EU level by the European Patients Forum, which is also part of our Health Outcomes Observatory project, and that's this Data Saves Lives initiatives. And I'm sure some of you, or maybe all of you, will know that. So for the patients, it's very important that data are used so that algorithms can be developed. And that's probably the case if you have a disease. So if you have cancer, for example, patients would agree very much to health data being used for research, because then, of course, they can see the benefit that better treatments can be developed. And the European Patients Forum runs these initiatives and tries to do a lot of lobbying that health data should be used for the sake of better healthcare. Yeah? And what we can also see, and that has also recently developed, that's called Vivli. It's by the big pharma industry developed or paid, actually funded. And the idea is to have a platform where clinical trial data could be shared. Yeah? So to have a way where big pharma industries can share their trial data for reuse again, yeah, without, of course, totally de-identified data, so you cannot go back to the patients. That's, of course, very important, and also to be analyzed in a very secure environment. Yeah? And I think when we look into the initiatives like H2O, that's, of course, focused on real-world data, so data that are collected in routine clinical care. But here, also for the clinical trials, it would be important that we make something out of the data, we use this data, and we use it also for further research, maybe to develop algorithms. But, and I think this is really important, also it should be possible, and that's important for us in the H2O project, also usable for patient and patient organizations. So patient organizations might also need data. Yeah? And it's not only the individual patients who need the data for their healthcare, to talk with their healthcare providers, to have some symptom monitoring maybe, but also for the patient organizations. So what's the wish list actually for the future? We want to have measurement standards, so ideally everyone would collect the same outcomes. We would want them implemented, so while we see there is a lot of these outcomes like the ICHOM set on breast cancer that I showed you before, there's very little of this outcomes data collection implemented in clinical practice. We want to empower patients with the data, so we want to collect, we want to give patients the possibility to co-decide what should be measured, then to collect data, of course, but also to use this data, yeah? To integrate this patient-generated data in electronic health records. And this refers not only to the patient-reported outcomes, but also to data collected from sensors, which is very important in diabetes care, for example. We want linkable data, so we do not want the data in silos, but we want the data really to be linkable between and between registries maybe to other resources, but in a very safe environment so that no one would be identifiable. We need a governance model for data access. We need more transparency of outcomes so that it's also clear, and we can also analyze whether we are better than other countries, for example. We need reasonable societal discourse. We have to take all these data protection issues very seriously, I think, and really discuss it with everyone. But we need a lot of technologies, and there is more technologies now that data do not need to be centralized, but they can remain where they are. And we run some federated analytics and validate algorithms on data that are not centralized in one place, but can remain in the hospitals, for example, or wherever they are created. Yeah? We need a better science literacy and maybe also a digital literacy in the population. And I think it will be very interesting maybe to see what also the patient representative would say to this. But I think that would be really important to start it very early already with young people. And I'm sure also the education that is offered here in St. Pölten contributes a lot to this. And we need the commitment of organizations, of course, to share their data also, because right now we have the situation that everyone has their own data, but very little interest in linking or sharing this data with other organizations. So thank you very much for your attention, and I'm happy to answer any questions, but you are the boss here, and you have to say whether that's possible or not. Yeah?
Thank you, first of all. And thanks for perfectly sticking to our time schedule. I think we have time for 1 or 2 questions. Yes, there's a microphone coming up.
Thank you. Thanks so much, Tanya. Just a question with regard to getting 6,000 people within a month to answer to your survey. I think that's amazing. How did you do this?
Yeah, that's a good question. We are working with external partners here. So we are actually commissioning someone to do this for us, because we have access to the patients. Yeah, that's of course possible. But if we want a representative sample from the general population, we need to ask someone. And Market Agent has worked with us here, and they have a standing panel, so they can access those people. And we are defining target quotas, so in the different Bundesländer, for example, or in different age groups, different gender. And once they are filled, then they stop the survey. So they invite people until we reach the target quotas. Yeah? And they have standing panels in different countries, and we have done this in Austria and Italy. But we would not be able to do it like that, because it's not any person who should fill this in, but according to the target quotas. Yeah?
There's another one.
So in your wish list, you mentioned that you would have to get organizations to agree to share their data. And I'm personally curious, in your experience, on a personal level, how hard do you find it to convince scientists to share their data and work together on this topic? Because in my experience, there's also in the scientific community a lot of Konkurrenzdenken, I'm sorry.
Yeah, and resistance maybe. I think it's a good question, and I would say it's not impossible, but near to that maybe, yeah, sometimes. So I think it's really difficult, yeah, and it's not only researchers, but also clinicians and organizations, yeah, like, but there are, I mean, right now, and what we think, what is important is to have something like an incentive, and what you can see and what we try to promote through the H2O project is that if you give your data and share them, you get more back, because then you will get larger data sets, because the data could be linked and you could have access to larger data yourself. Yeah? And that's, of course, good if you want to publish something. And the question was now, if you have how we got the 6,000 people, yeah, and I mean, if you look into the big impact journals, the sample size really matters, yeah. So I think this is, and I mean, also for validating all types of algorithms, and I'm sure you will talk more about that. Also, the sample size is really important, yeah, and also the timeliness of the data. Yeah? So if the data is very old, it's like with this COVID thing here, yeah? No one is interested anymore in COVID booster vaccination right now. Maybe it changes once we get into the autumn again, yeah? But right now, it's really no one interested, yeah? So if the things get old, it's not of interest, yeah? And I think what we will see maybe in the future, and what is more and more important, is the time to analysis also, yeah? So if we have these kind of infrastructures already set up, we can easily add something or ask patients other things, yeah? And that would really benefit researchers, I think, yeah? Both on the public and the private side, yeah?
Health data is, of course, always sensitive and private data. So what would you say to patients whom you want to have to agree to have their data contributed to a science project, who are maybe weary of, can anybody maybe then access my private data? Can somebody learn about things that I would like to keep private? So technologically, the way that data analysis that you're doing works today, can it be done with aggregated data in such a way that privacy issues are not a big thing anymore? Or what would you say to
that's a
patients
good
there?
question. I think one thing is that the patients are less worried, and they are often more convinced that it's important to have some kind of governance model how the data could be shared. Yeah? Then it's the researchers or the clinicians, yeah, who are much more, or the organizations, yeah, on where the transparency might create issues. Yeah? So I think patients are often less worried. However, I think important is that we need, and someone said that recently, also and we discussed it in another conference, the problem is that aggregated data is not enough. Yeah? So if you want to run or test algorithms, you want to develop something, it's not enough to have aggregated data. Yeah? So the chart that Florence Nightingale produced is nice, yeah? But this is produced on, it's of course aggregated statistics in the end, but it's always on the microdata from the patient. So we need access to the microdata from the patients. But it's not important whether it's my neighbor, for example. So I don't want to know what my neighbor, what the disease or yeah, whatever kind of health status. It's important that we have data from real patients. And there are right now a lot of different approaches. And one is this federated approach and creating safe environments where you could, instead of pooling the data in one place, have them remain where they are and run some federated analytics. But another approach is also to synthesize data, yeah? To have synthetic data where you produce a digital twin. Yeah? So you don't have the real patient data, but you have AI synthesized data on some core characteristics of the data set, and then the data set would be similar to a certain percentage to the original data set in the parameters you would want to analyze, for example, diabetes outcomes or whatever, but the patients are not real anymore. Yeah? And maybe that could be also approaches where you could run algorithms, and there has been also a testing where people compared analysis from the synthetic data with the real data, and it's the same. Yeah? So I think there are approaches how we can do this in the future in order to make this data accessible. Yeah?
Thank you so much. So there's a lot to look forward to in this area, we see. Let's thank Professor Tina Stramm again. And we are moving up to our next keynote lecture. Lukas Sepper is the co-founder and head of growth at Xund AI, which is a company focusing on different kinds of data-driven healthcare approaches. I particularly like the name Xund AI. Xund already, of course, being the Austrian term for healthy, but spelled with an X here, and AI, well, everybody knows what that is. So Lukas Sepper, please.
Still doesn't work. Okay, then I will take this one. Yeah, thanks for the introduction. Thanks for having me. I think it won't take that long, because also thanks to Professor Stamm, I think a lot of points, a lot of topics were already touched, and it most of them really resonated with me. I think we share the same vision of how healthcare should look like. Looking at the keynote, I have to talk to my marketing department, but also spoiler a bit, we are actually not a platform, and during my talk, I will be quite tough on platforms. And when I'm speaking of platforms, I'm always looking at it in the context of data. So if I'm talking about platforms in the context of data, I'm always looking at how these platforms control both the data quality and the data liquidity. And I think going forward, we need to, as Europeans, as citizens of the European Union, we have to take care that these platforms don't own both of these qualities. But let's get started. And before I start, I would like to start with a question, because this will be the common theme of my talk. So, what's the purpose of business? I expected that. But more than that, any other suggestions? Okay, that's pretty good. So how I would define it, I mean, profit is one part of it, right? But how I would define it is that the purpose of business is to create long-term value by balancing the interests of different stakeholders you will always have, but also contributing to the greater good. The greater good, that's the common theme in my talk today. And I will first share the micro perspective, that is gesund. And in the end, I will also share the bigger picture. So, Professor Stamm already mentioned that. When we started gesund 5 years ago in 2018, we were looking at the healthcare industry and what we have seen back then, and unfortunately it didn't change that much until today. When we looked at the industry, we saw that more than 50% of the patients don't understand basic health information. And at the same time, the willingness to understand the knowledge and the willingness to be part of the healthcare equation, to drive or to take part of the decision-making process is there. So there's an increasing demand. Now, the first way, that should look different, but anyway. The first way of patients to get that kind of information is usually Dr. Google. Since this year, it might also be ChatGPT, but everyone who has done that before knows that this is the most accessible way to get at least some information, right? But also everyone who has done it before knows that it is not that reliable. And the reason is pretty simple. It was never intended to be a medical device. It was never intended to provide medical guidance. Now, then the question is, why do people still use it? One answer is that it's accessible. But the other answer is that the healthcare system is under pressure, right? So and we don't need to look at developing countries. If we look at Germany, so the left part should be the country outline of Germany. If you look at Germany, then the average patient visit takes less than 5 minutes, right? Doctors just don't have the time for patients anymore. And if you look at the UK, which is way more depressing, I think, is if you call an ambulance in 2023, you have to wait for 90 minutes. So if you have a heart attack, you're dead, basically, right? You don't need to call them. Now, the question now is, how do we solve that? And we think, that's one of the common understandings here in the healthcare industry, that it's not feasible anymore the way how we interact with healthcare. So one way how we could, at least parts of that, is by digitizing and automating patient interactions. That means to enable that, we not only need data, but a common understanding and language of data. And as I said in the beginning, instead of being the platform itself, we wanted to power the platforms out there. So we are staying behind the curtains, and what we do is we're providing the technology, some would say the intelligence layer, to healthcare companies. And by doing that, we enable our partners, such as insurance companies and hospitals and pharmaceutical companies, to interact with the patients digitally, to automate certain interactions, and to provide medical guidance. And these fancy icons on the right side are just some certifications from TÜV Süd. Today we are a medical device manufacturer. We have a medical device on the market, a Class 2 medical device under the new medical device regulation. And that was basically 2 years ago the game changer for us, because that allowed us to talk to these guys and to help these companies to start with digitizing the ecosystem. And I would rather talk about ecosystems, because that's actually what we are seeing in healthcare. That it's less about platforms, but more about ecosystems and how these ecosystems can work together. And what you see here is basically the engagement layer, right? So patients can interact with their, in this case, insurance company, even before they go to the doctor. They receive medical guidance through our layer, through our intelligence layer, and then they get connected to the right point of care. But the end game is this one, right? So we call that customer hub. But in the end, that's all patient-generated health data, structured in one hub. Some would call it platform, but this data can also be extracted, right? So our customers can take that data, use that in their BI tools, and we're just here at the beginning, right? So that's only the data that is coming from us. Once we connect our solution to telemedicine providers, to digital health solutions like DIGAS, right? To hospitals, so to the offline world, this data will be more holistic and available to not only the customers, but also the patients. So that's aggregated data, but the personal data, that is always in the hand of the patient itself. Now, first 5 years, we'll have our anniversary in July. First 5 years, we focused very much on the diagnostic part. And today our solutions are very much focused on how we can help patients that have some symptoms, that want to go to the healthcare system. Next 5 years, we want to focus more on the preventative care and the monitoring side that was also touched by Professor Stamm. So how can we rethink the way patients interact, not only for symptomatic patients, but asymptomatic patients, but also patients that have a chronic disease, for example. And the question now is, how did we manage to do that, or how do we plan to do that going forward? And there are lots of answers to that, but 2 are really important to acknowledge also in this round. First of all, open data, right? When we started 2018, we had one hypothesis, that the knowledge, the medical knowledge is already there. It's just hidden in literature. So the only thing we need to do is extract that knowledge. Now, what we did is we looked at PubMed Central back then, which I think today it has more than 5 million medical publications. We had one medical co-founder, so we calculated how long it would take him to read through all of that. It would be hundreds of years. What we did is we talked to the TU Wien, and since then we have a cooperation, and we looked into natural language processing models, right? And that allowed us to analyze the data much faster than with just one doctor. That was the one thing. So we had access to data. And the other thing was open source technology, right? In 2017, Google launched their, or published their transformer models. We could use that. We optimized it for our use case, and that really enabled us to leap forward. So I think that combination, at least from a tech side, really helped us to move the needle. Now, the bigger picture. If I look 5 years ahead, I look at 3 scenarios. Actually, I pitched that probably a year ago to ÖGK. Back then, they thought we were heading towards Captain America. This week, European Parliament agreed on the AI Act. So I would say we're quite in the middle. And some other legislations are coming, like the European Health Data Space, the Data Governance Act, Data Act, etc. So I would say, if you ask me, I would go for Garden Eden, which would be a highly competitive ecosystem in Europe that is highly regulated. And in the end, I also have a wish list. That's why I said in the beginning, I don't want to be associated with platforms, because platforms are bad. Bad in the sense of if they, again, own both the data quality and the data liquidity. And there's reasonable evidence that platforms itself lead to or slow down innovation, right? They concentrate power. And in the end, the race of AI is all about monopoly, right? And we as citizens, we as founders, we as Europeans, we have to push against that. I think my wish would be that we have an ecosystem that is pushing against big tech in the US and big state in China. Second thing on the wish list, which is maybe you wouldn't have expected from a startup. Regulation is good because it shows trust. And in the medical domain, you have to play by the rules. So there's the medical device regulation, there's the Data Act, as I said. I think all these will help us to also include the patients in the long run, right? Because without the patient's consent and without the patient's participation, neither the industry nor the scientific community can move forward. And then lastly, I truly believe that data has to be a common good. I don't like the comparison with gold, because that usually would mean that somebody owns it. I don't think that this should be the case with data. Yeah, that's me. You can scan the QR code, and I'm also happy to answer any questions all day.
So, thank you very much. I think, again, we can make time for 1 or 2 brief questions. There is one over here.
Really interesting. And my question concerns regulation. I'm really happy to hear that you're for regulation. The only thing is that there's usually a time lag between when the EU comes out with a regulation like the AI regulation and when the AI technology is already kind of widespread. So for example, with ChatGPT, there has already been a lot of European data uploaded to ChatGPT before this regulation is actually there. So I'm just asking you as as the head of a startup, do you have a personal kind of an ethical code of conduct that you would think about before adding a new tool or so on to your product?
You mean on a micro level?
Right, where it's like, okay, maybe some kind of, what would you say, okay, maybe for that we need to wait before implementing and so on?
Yeah, I mean, look, in our case, it was a human being, our medical co-founder, right, that was always pushing hard on technology needs to be ethical, and everything we do needs to be reasonable and explainable, right? So in the end, it's the people itself, right, that you get on board, or that you have on team that you need to align to a certain ethical framework, right? I mean, in the end, there's also no workaround for that, right? And I agree with you that regulation is slow, but when it's there, right, then it's showing the way. So I think in the meantime, we have tons of guidelines, tons of frameworks we can work with already. And even if the AI Act, for example, won't be enacted before 2026, it already serves as a guideline for decision makers, right? So they will be cautious now to ask the right questions, right? Is this technology ready to be provided to patients or in a medical setting, right? Can we explain it? Is the data accessible, right? Is the model open source? These are all questions we need to ask before we use the mantra, move fast and break things. I think that's
yeah, thank you.
Shouldn't be the case anymore.
There is another question right here in the front row.
Thank you. I'm here as a patient, advocate, as a patient. I have no problem giving my data, but I want to know if the results are okay. So is there a check? You had you showed your system. I think I got it right. Patients are guided through questions to find the correct doctor, the correct address. But is there also a reflection? Was the tip okay? Was it the right doctor? Was it the right diagnosis? This was the question. And I have one remark. As you gain your data through the web, but what about all this data before the web? I mean, there's lots of medical knowledge not built up in the web correctly.
Okay, first question, I mean, we want to get there. We are not, because we don't have a common understanding and language of data, right? It's starting, so these ecosystems are just building up, and where ecosystems are ready to have this common understanding, there is a loop, a feedback loop. For example, we're doing it in 2 emergency departments where we are checking that retrospectively, both the working diagnosis from the doctor, but also the discharge diagnosis. That's the one thing. And the other question?
It's just about the knowledge you gain, but not from the web. I mean, there's not a lot of medical knowledge not in the web.
I mean, I wouldn't say that PubMed Central is web, right? So in this case, it was, everything is peer-reviewed.
Okay.
These are publications that are out there for decades, some of them. So that was I think this will remain the highest quality, right? Still peer-reviewed, where we know the outcomes are validated. And then there are different layers below that, right? So patient-generated health data with no validation, and then we have the real-world data coming from hospitals, primary care settings, etc., where we see that the data is incomplete and may not be validated already. But we need to combine all these layers to have a full picture. Right?
Thank you very much. Okay, I think, yeah, thank you. So let's just move on to the next talk. Well, I myself have a background in theoretical quantum physics, and if you work in that field, then you're often faced with the criticism, well, this has nothing to do with the real world. This is purely ivory tower academic stuff, and sometimes I object to that quite fiercely, but sometimes I must admit this is true. Yeah, there is this kind of research which is up there in the clouds. But today, and right now, we're going to talk about the other end of the spectrum. Research which is very, very applied, so I'm very happy to welcome students to the stage who are going to present their student projects, which are directly linked to applications. We do not have so much time for that, but I would like to point out that those students' presentations are also accessible in the back of the room, you will see presentations, you will see posters there, so do not hesitate to approach the students afterwards or in the break and talk to them about what they're going to show you right now. So it's just a little appetizer, and please take the opportunity later to talk to everybody in depth if that's your topic. And so I would like to welcome to the stage Svetlana Kren and Christoph Planck, who are going to talk about science of life.
So, hello everybody. Thank you for the nice introduction. Once again, my name is Christoph Planck, and this is Svetlana Kren, and we're here on behalf of the Science of Life team of FH St. Pölten. And as there will be no time for questions at the end, we kind of like to flip things around and ask you a question at the beginning. So we're interested in who of you would feel confident in a real-world scenario to provide basic life support to a human being. If you're confident, please raise your hands. Yeah, Professor Stamm. Good. Thank you. Okay, I would say it's around 70% guessing, roughly. Well, it might not be a very comforting thought for a Friday afternoon, but I invite you to imagine the following just for a second. Right here, your neighbor sitting next to you suffers a cardiac arrest, and their heart just stops beating, because this is what happens all the time. And from this second on, their life clock starts ticking. And to show you some data that drives us as a team, the life clock is ticking for around 15,000 patients per year in Austria. 15,000 people suffer a cardiac arrest. Now, in that case, your chance of getting adequate life support by bystanders, meaning chest compressions and rescue breaths, is actually quite low, only around 60%. So not a lot better than flipping a coin. Now, imagine the following. Somebody walks by out there, they see somebody lying there, and if I did the math correctly, they're part of the 47% who actually don't lack health literacy, and they want to help, because they know that after 10 seconds, people lose consciousness, because this is how long the brain can go without oxygen. And after only 40 seconds, there's no activity left on the ECG anymore. So these people come in, and they know that immediate initiation of life support measures could double or triple the chances of surviving a cardiac arrest. But they're standing there, and they just don't know what to do, because they never had a chance to learn. Well, to show you some more data that especially drives us, this is what one of 10,000 people in Austria could have said. People with severe hearing impairment. Hearing impairment is so severe that they have to rely on sign language for daily communication. And if you're one of these people, your average waiting time for a basic life support course, remember, you just sign up for this if you want to do your driver's license, and 1 week later you just do it. In this case, you would have to wait 1 year. So 365 days of waiting to learn a skill so crucial that we as a group think everybody should have. And this is what we want to change. And Svetlana is going to show you how.
So let us introduce you to Science of Life, a digital solution to support people with severe hearing impairment in learning basic life support. Let's quickly see how it works.
Du hast festgestellt, dass diese Person bewusstlos ist und nicht atmet. Wenn du keinen Defibrillator zur Stelle hast oder dieser auf dem Weg zu dir ist, beginne mit der Herz-Kreislauf-Massage. Knie dich dafür neben die Person, leg den Ballen einer Hand auf die Mitte der Brust, leg den Ballen der anderen Hand auf die erste Hand, verschränke deine Finger ineinander, halte deine Arme gerade, bringe deine Schultern senkrecht über den Brustkorb.
So what makes Science of Life special? As you could see, Science of Life is easy to use. Everybody, independent of their background, health literacy, or general knowledge, can use it. No distraction, no glitter, just plain well-prepared content. and Science of Life is unprecedented. Until now, there are no widely available solutions for people with severe hearing impairment, neither digital nor real-world courses. And Science of Life is also accessible. After researching and talking to the community, we create a tailored-to-need solution for people with severe hearing impairment. We merged visuals, subtitles, sign language, and also auditive content, because in some cases people can still hear us a little bit. And with our gamified approach, using a quiz, we make sure that the knowledge stays for good.
We now almost have 5 seconds on the live clock.
5 minutes, sorry, 5 minutes,
Sorry.
the first brain cells of your neighbor are dying. So let us conclude. We are convinced that really everybody should know how to save life, also people with severe hearing impairment. So we can turn this into this again. Thank you, and see you at our booth. One more thing, I'm sorry, one more thing. Your neighbor, of course, survived because you knew what to do and provide basic life support. Thank you.
Thank you. So as you could just see right now, the students presenting their projects are just part of a team, so it's usually more than those students you'll see here on the stage. There are others too. Okay, so the next project is going to be presented by Julia Böck and Tobias Eder, and it's called Voice Assistant Patients. Please.
So, hi everyone, this is Tobias and I'm Julia, and we are really happy to represent our team Voice Assisted Patient, or short VAP. Today with us is one of 3 million emergency patients the Red Cross has each year. 1 of 3 million. This is our patient, this is Ted. Ted knows the situation really well, but myself as a paramedic can understand the patients also. An emergency situation is stressful. You have to think of your data, your medical information, and all of that in a short and really fast time. So, Ted doesn't have the problem. Why? Well, he uses VAP, or Voice Assisted Patient.
You might ask yourself now, what are they talking about? Let me tell you more. Voice Assisted Patient is a tool that consists of 3 pillars. The first pillar is a voice assistant, which allows users to record different types of the medical health data, such as continuous values for blood pressure, coagulation values, or blood sugar levels. The second pillar of Voice Assisted Patient consists of 2 different web interfaces. The first web interface is meant for patients to manage their own health data and to record static data such as previous illnesses, medication, and allergies. In case that someone needs to change previous input data or that the voice assistant is broken, they still can record their health data by using this web interface. VAP offers a second web interface for medical professionals and, for example, paramedics, which displays the most important information and gives a brief overview of the patient's condition to shorten diagnosis time. The third and the last pillar of Voice Assisted Patient is a unique QR code. This QR code grants fast access for paramedics and medical professionals to the web interface I just mentioned. This saves precious time for our patient Ted.
So, let's take a look at what Ted actually recorded as his health data. This is his personal dashboard. As we can see here, Ted still has to take penicillin and paracetamol. Also, Ted can see his recorded data by the visualizations, but he can also look at his last recorded value, maybe to double check, or he just wants to know it again. That he can see by the yellow boxes on the right side. What you can also see are buttons at the top. Ted can either edit his profile, edit his data, Or if he wants to take his data to his next visit to the doctor, he can simply download it by his personal dashboard. The last button you can see there is the medical dashboard, but Tobias will tell you more about that one.
This is the impression that the medical professionals and the paramedics get from VAP about Ted when they scan his QR code. Additionally to Ted's personal dashboard, we can see here more information about his previous illnesses, Ted's medication, and his allergies. Furthermore, the color of the displayed vital parameters indicate if some values are out of range. Here, for example, Ted's body temperature is slightly too high. By tapping on a specific value, for example, Ted's blood sugar, we can get more detailed information, since all the values Ted measured will be displayed as a graph. So this dashboard saves pretty much time in emergency situations and saved Ted.
So, thanks to VAP, Ted had one stress factor less because his data was clean in all of VAP. We are really looking forward to seeing you at our booth back there.
Thanks very much. So the final presentation before the break is Julie Rejondic and Markus Ochsenhofer talking about MedBuddy. Welcome.
Have you ever observed how healthcare professionals and patients communicate when they don't share the same language? They talk with their hands and feet, almost looking like professional pantomime actors. We are a team of radiographers and a user experience designer, often coping with an issue that we believe most of you can relate to. Language barrier is a global issue and can happen in any situation. So is the case in Austria. Language barriers and miscommunication in healthcare settings are especially problematic, having a negative impact on the quality of care. Statistically, there are over 300,000 people in Austria who cannot communicate effectively in German. And we, as healthcare professionals, we often find ourselves in situations where we can't communicate fluently with our patients, which leads to stress and frustrations on both sides. In those cases, we resort to nonverbal methods like gestures, even facial expressions. It's not ideal, of course, but it's something we do to get by. Now, those of you who had the computed tomography or CT scan already might recall that this can be quite challenging with all those instructions in medical terms. And sometimes anxiety might kick in, right? Now picture other people who struggle to understand information not only because of language barriers, but due to other communication barriers like anxiety or physical, emotional, psychological, just to name a few. For them, medical terms are even more confusing. Miscommunication can result to patients not following instructions, and in turn, they can't have a proper examination. Aside from that, many medical facilities still rely on paper-based questionnaires. All those printing, distribution, archiving, you get the point. Now, to tackle these challenges, our team came up with a solution that Markus will enthusiastically tell you more about.
As you can see, our group has found 3 major problems in the Austrian healthcare system. That's why we had to create not 1, not 2, but 3 solutions to face those issues. Our first solution is an application that provides medical information in multiple languages. Our second solution is an explanation tool that makes it easier for patients to understand their examination. And our third solution is an environmental-friendly, non-paper-based digital information sheet and questionnaire. But guess what? These are not 3 different solutions. This is an all-in-one healthcare breakthrough tool, and we call it MedBuddy. So let's take a look at it. When you first start MedBuddy, you will be already greeted by our first solution, the multilingual application. On this language selection page, you have the possibility to choose between many different languages in which the whole app will be displayed later on. After this, there's a small registration page, which is followed by our second key solution already, the patient-friendly explanation tool. Because on this page, you have two options. You can now either read the informational sheet, or for an even more enhanced experience, you could also watch a video where a digital human will explain the examination to you, audibly, visually, and in text. After this, there's a mandatory questionnaire which you have to fill out. But don't worry, there won't be any paper sheets included anymore. Everything is digital now, which was our third key solution. And then, if you agree to the examination, you can simply click on agree and sign with your finger. But that's not all. Here comes the second part of our patient-friendly explanation tool, the frequently asked questions page. This page was designed to reduce all the remaining concerns that you may have, and again, all the questions and all the answers are displayed in the language that you understand best, which is pretty cool, right?
Right. So MedBuddy wants to ensure proper communication between patients and healthcare professionals. And in the future, it is aimed to add more modalities and languages to our software, combine it with other translation tools, and integrate it into a hospital information system.
It is MedBuddy's goal to make healthcare more accessible, more inclusive, and more convenient to everyone. We believe that good communication is the key to good medical treatment. So thank you for now. Please come to visit us at our booth to see MedBuddy in action, and of course to get yourself some popcorn. Thank you.
Thank you.
Thanks a lot to the team of MedBuddy. So now it's time for a short break, about 30 minutes. So please do check out the booths. I think there is something to drink outside. So take the opportunity to mingle, to ask questions that could not be asked after the talks, and let's meet here again at 2:45. See you later. Our microphone is on again. Thank you for coming back, everybody. We'll give the people who are still outside 1 more minute or so, but start taking your seats, please. So until everybody's settled in, maybe we'll do a quick survey. Who of you used AI tools in the last few months at some point? Actually, this is almost everybody. So let's check. Who of you used AI tools to create texts in some way? That's a lot. Who used it to create images? Yeah. You tried, but you failed. Yes, I feel you. Same experience that I made. And who used artificial intelligence tools to do language translation? Okay, so all those possibilities are quite popular in this audience, I think. And I'm sure when we ask the question again next year or in 5 years, then the percentages will be even higher. So I think it's great that we have an artificial intelligence block right now with 2 talks about that topic. The topic of artificial intelligence, of course, has already been touched upon in the first part of today, but now we're going to go in a little bit deeper. So I'm very happy to welcome Christoph Russ. He's a technical program manager at Amazon Web Services, and he's talking about something which I've been told about for decades. You know, in the old days, maybe 20 years ago, it was science fiction. People said, yeah, well, one day we will be able to use artificial intelligence, maybe even in diagnostics. And as you all know, this time has come, and this is already there. It's not science fiction anymore. So I'm very much looking forward to what you have to tell us about that. Thank you.
Thank you. Thank you very much. So thanks for having me. I'm very, very excited to be here today, and I want to tell you a very, very short story to start with about football. So last year, a friend of mine, he asked me, hey, come play with us. We have a practice session. So I went, and I didn't play for maybe 20 years before that. So of course, I hurt my ankle, and I thought, okay, what do? You go to the doctor, you get checked out. So doctor said, yeah, we need to do an MRI scan. Great. So I went and I got the MRI scan done and came back with the radiology report. And doctor said, all looks good, the ankle injury that you got, no problem. But we found something else. So there was a lump in my foot that they had to check. And she said, here, take this disc where your MRI scan is on and bring it to this next doctor. And please show them, promise me that you'll show them, and they can tell you further what to do. Luckily, there was nothing really to do, but it showed me 2 things. One is that doctors like to send you to other doctors. And the other thing is that they still don't have a good way to share information and to share images with each other, even in today's age, right? So I want to take the next 20 minutes to talk about medical imaging and how technology can help radiologists. And what you might be aware of, because this audience is quite health data driven, I think, is 30% of the data that we produce is healthcare data, right? And 90% of that healthcare data is medical imaging data. So who of you has previously also got an X-ray, CT scan, MRI? Okay. I think most of you, and statistically, you'll get one or multiple of those imaging modalities done to you, just like I did. And that includes also visible light-based image modalities such as endoscopy-based or now pathology imaging. So there are 5.5 billion exams done annually in the world. Average size of such a procedure is 150 megabytes, but this will significantly increase with modalities such as digital pathology. And how can we help doctors that still give you, discs or CDs or whatever they use, with making that process more efficient. So in Germany, for example, in 2018, I think 130 million X-rays were done. So the population of Germany, who knows? 80 million people, yes. So 130 million X-rays, 80 million people. And you have maybe 400,000 physicians. 2% of that is estimated to be radiologists, which is about 8,400, calculated that. So 8,400 radiologists, millions of images. How do we help them read reports better and make this process more efficient so that we don't have the, this thing that we saw before where clinicians only spend 5 minutes with the patient? So one thing, by the way, I didn't mention this in the beginning. I think I'm with Amazon Web Services, but I think as was already introduced. And we help physicians, for example, or solutions to be built on the cloud, for example, with cost-effective storage, so that hospitals and clinicians can go and focus on their patients and rely on the solutions that have been built. Yes. So King Hamad University Hospital is one of our customers here. They are a 600-bed hospital, and they have moved all of their medical imaging data, which is about 44 terabytes at the time, to AWS. And what did that give them? Well, the one thing here is a 40% storage cost savings, but that's not the primary really benefit they reached. The real benefit is increased staff productivity and more space to do innovations. Now they still ingest about 1 terabyte a month into AWS. So while cost savings like this is great, that's the radiologists typically don't worry about it that much. They want rapid access to their images. So just like I said before, I had an injury and you need rapid access. You want those images if they're already available. You want them at a moment's notice. And how can you do that with the right data at the right time? UC Health is a medical network in the US, and they transformed all of their medical imaging applications to be moved to Visage imaging, which is running on AWS as well. And the benefit they saw was collaboration, right? They wanted their radiology departments in their different centers to collaborate. Now, this solution allows them to load the study in under 0.3 seconds, which is quite significant improvement for their radiologists. So what is AWS, and why do so many people actually use it for healthcare data and for medical imaging data in particular? AWS is building very comprehensive, broadly adopted cloud. We have well over 200 featured services, and we allow you to scale your solutions globally, right? You can look at the millions of customers of ours that do this. These include startups, enterprises, also government agencies, really anyone who wants to build less infrastructure and wants to focus more on the solution. So I mentioned Visage here, but if you look at the slide, so just some of the imaging solutions running on AWS. You might actually know some of these names, but I just highlight Philips quickly, who built the Health Suite to run on AWS. And that allows them to really connect different devices and solutions together, right? So they also now use AI tools to innovate further and have deployed this in our environment. So how can we help as AWS? We're an infrastructure provider, right? With services, and one of those for medical imaging in particular that we introduced last year is called Amazon Health Link Imaging. And it's a storage service for medical imaging that allows you to ingest petabytes of data. We touched on, storage efficiency and cost is a major factor. So this service, by reducing data redundancy, will allow solutions to build more effectively and save up to 40% of costs. And we also talked about the retrieval times already. So this same service allows you sub-second retrieval times to improve clinical workflows and give access to images really from anywhere in the world. Now, that's kind of the future and how solutions will be built in the future, but I also wanted to talk a bit about what already happened and how we already were able to help some of the research departments, such as the one in Radboud in the Netherlands, to really advance their research collaboration globally. So Radboud has one of the leading medical imaging departments and research departments in the world. And they had a real need to give access to clinicians and researchers around the world when the global pandemic started. Because what they tried to do is help radiologists and clinicians and researchers work together to build AI for detecting COVID. So their platform, called Grand Challenge, was migrated to AWS in 2 months and has been running there ever since. What does the platform do? Well, it allows, like I said, collaboration. Through this tremendous effort of theirs, they can now support 80,000 researchers and clinicians working together in this platform. They have well over 300 open source science projects on there. They deployed over 2,400 now, I think, AI algorithms on their platform. And it's all available to you as well. So you can go there and you can try it out and you can collaborate in these challenges, one of which is called STOIC, which was one that actually was initiated with the APHP in France, who recruited 10,000 patients and accumulated a large CT data set to detect COVID. And the run of this challenge, there were about 168 algorithms submitted and then compared, right? So they wanted to see, who can solve this best. What they also managed to show at Radboud is how you can bring those algorithms then closer to the clinician. So what you see here is, on this side, you'll see the Grand Challenge environment running with the community of builders. Whereas on the middle, you see a university medical center. It could be anyone's, it could be here in St. Polten, which deploys that open source solution into their own environment and then moves the algorithms that have been trained here into their own environment. This can be research access based, this can be a clinician who wants to test out a certain algorithm on their own data. So really bringing the compute closer to the data here without having to share it. We talked about this earlier, I think. It is very, very interesting for a lot of these departments. So that's still a research application, though. So how many of those algorithms do you think end up in clinical practice? Not a lot, right? There's most of them don't make it. These are thousands of research algorithms, of course. But if you want to know, between 2015 and 2020, in the US, about 222 AI-based medical devices were approved by the FDA. In Europe, it was 240 CE marked. And if you look a bit closer here on the right, you'll see that 129 of those, so the vast majority, are for radiology applications. And that's why most of the startups out there build on AWS to really innovate and move quickly, right? Who is not on here, because I didn't manage to add them in time, is ContextFlow, which is actually a Vienna-based startup from the Medical University of Vienna. Georg Langs is part of that. He managed to also use AWS to increase access to AI and accelerate the radiology workflow. So that's the reason why people build with us in AI, to really accelerate, to scale, and to be flexible, right? The thing that everybody talks about now, of course, generative AI. I just want to highlight that we also announced a generative AI service called Amazon Bedrock, which is meant to democratize the access to AI. It's not meant to isolate you. It's meant to support anyone building on top of it. So that's our vision for this service that really will help scale many startups to building their solutions on top of it. If you want to get started, I mentioned one of the challenges here in the Stoic Challenge, and others from the Grand Challenge environment from Radboud, they moved their data actually into an open data registry on AWS, which anybody can apply to use if you have data that you want to share. Costs are covered by us. Also, Mona data sets are on there if you're familiar with that space. Also, if you're a researcher, you can talk to me afterwards and learn more about the Cloud Credit for Research program. If you want to improve health equity, which is an important focus of ours, we also have a program that will help you receive probationary credits to do that. So, yeah, come talk to me. We can start with a workshop, or we can do anything together that you think is valuable. Thank you very much, and I hope I stayed within the time.
Thank you very much for adding this very interesting aspect to our discussion. So are there questions? There is one right there. Do we have somebody with a microphone? Yes, we do. Here in the second row.
Thank you for the talk. I have a question concerning the view of academia or the educational side. So if I want to participate in this new world of large language models, cloud computing, and so on, in the field of healthcare, what actually would you study, or what kind of skill set do I need in the future? I mean, is it still okay to study medicine with a focus on radiology, or do I have to rather study data science with a background a specialization in a field, in a medical field, or is it something completely different, or are there even skills that are not taught yet? So what do I need to get started? That's my question.
So I think it depends a lot on what you want to do. The thing that we help you do is use AI much more easily, so that you don't have to study data science, and you don't have to be an expert in machine learning to also use these tools, right? But of course, if you want to build the next generation of whatever comes after the transformer models, you probably want to become an expert in machine learning, yes. But I don't think it's necessary anymore. The vast majority of applications can be built on top of those large language models that are also becoming more and more available because they're published on Hugging Face, and you can retrain and fine-tune those models very easily now, so at also reasonable costs. So it's really something that you should learn how to do that, I think, how to test and validate the output of those models, but also how to adjust them to your use case.
Any other questions? Yeah.
Thanks very much for the interesting talk. Coming back to your story, which I really liked about the disk, and a similar one is doctors faxing results to, using a fax machine to transfer results. I've heard that one too. There is some kind of resistance to, for example, using AWS to transfer data. Do you have any ideas how to actually get to the clinicians on the ground, not the ones working in research areas who are maybe a little bit more open to experimentation, but the ones who really want just something that works reliably, and so that's why they go to the fax machine, that's why they go back to the disk for data transfer?
Yeah, so I think the question is, how do you motivate clinicians to take the next step, right? Mm-hmm. It's difficult, right? I think if they see the value and if they understand that it's really going to improve their work, then there's going to be not a big question for them on if they should adopt, but when. And which solution, well, we're trying to enable any kind of solution that makes sense for them and not one in particular. So whatever is being built, we're just trying to help make that building process easier for you.
Okay. Yeah, one final question right here.
Yes, thanks for the excellent presentation. I have a question regarding the democratizing of the AI, and we have discussed that also in other occasions. How far should that go? Is it democratizing for researchers, or should it be for everyone? Should everyone use AI tools? Should everyone have access to data? Where do you stop this? And who should be, or should no one be excluded? Do the people have enough literacy? Would we then give lots of data to all the science skeptic people who will prove that science doesn't work at all? Or is it? So I think this has a lot of pros and cons, maybe.
Yeah, I think what you'll find here with the service that I mentioned is that a lot of partners will produce models that will become available there. So these are also expert organizations that have built those models. Of course, you can also train your own model. Nothing will stop you from that. And even if I don't provide you the tools, you can still do it, right? I think what we need to show is how impactful and how valuable are those models. And I think in research, that's what we do, right? We test and we experiment with that.
Okay, so thanks again. Let's thank Christoph Russ for his talk and answering these questions. And let's move on to the next topic. We heard a lot about technology and how it can help to help with diagnostics especially, but there are also other questions, of course, when it comes to healthcare. For example, how can we make sure that the right kind of people are at the right place at the right time? And that too is technologically quite demanding, and I'm happy to introduce Andreas Diensthuber from Davos AT to talk about that. Thank you.
Yeah, thanks for... Hello. Yes. Yeah. Thanks for the introduction. Thanks for having me today. As already said, my name is Andreas. I'm one of the two co-founders from Davos. And so the first question, who is Davos? So we are an interdisciplinary team of health and tech enthusiasts. So currently we are around 20 people located in Linz and Graz. You can imagine around 10 health professionals, doctors, nurses, therapists, and the other 10 ones are tech people, data scientists, software engineers, UX designers. And what I want you to keep in mind is that everything I will tell you right now is, first of all, developed by this team, and second, it's driven by research. So every algorithm, every model I will explain to you today, or I will share with you today, was originally come from research. And as you can see, we already have more than one partner who is trusting in what we are doing. So first of all, Lucas, you have to be strong right now, because as you can see, we call our tool a platform. So I'm sorry for that. Maybe you can help me afterwards to find a better term. No, I'm just kidding. So what are we doing? So first of all, of course, we try to link data. Sure, when you talk about AI, you need data as an input. And we have 3 main data sources that we are using. And this is different kind of data than my colleague before was mentioning. It's not imagery data. It's data, for example, like nursing documentation data, it's billing data, it's data that is created within the organizations in the data use. So this is the first main data source. The second one is the external side, for example, epidemiological data, demographic data. When you think about the pandemic, we, for example, created a model that was able to to predict on the regional level the infection rate and was linking it with the resource demand afterwards. So these are the first and the third one. And in between, you see our warehouse, our specific warehouse. I will explain it in a minute in more detail. And by using this database, we are able, to provide different kind of services. Today, I focused on, the health workforce data services. Of course, we have additional ones, for example, regarding, the supply chain, for example, or material or medication. But today, because we all know that we have a huge problem regarding the health workforce, I decided to focus on services that we can provide on our platform to manage workforce. So, as I said, our warehouse, what is our warehouse? And of course, when we talk about data within hospitals, we all know that there are many problems regarding the data quality, missing data, inconsistent data, and things like that. And so we decided some years ago when we started our research that it would make sense to have a kind of our own standard which allows us to describe what's going on within a hospital, meaning that we are able to describe what are patient-related and patient-non-related tasks, where are the differences between different medical specialties, between different professional roles, different hospital types. For example, there's a difference if you talk about processes within the AKH Wien, or for example, within a hospital somewhere in the Waldviertel. And this is a data source that or a kind of database that we have created on our own, by our health team in the last few years, which can be linked to any kind of documentation data right now. And this is something very important. It's not big data, of course, but it's very unique data and very, very clean data that helps us to answer the questions our customers are asking us regarding resource planning. So current challenges, it's not a big surprise. We are running out of health professionals. And this is something that is not just going on in Austria or Germany or Europe. This is something you can observe, across the world. And because of an increasing, demand for health services because of the aging population, we can expect that this will, continue in the next, 10, 20, 30 years. So the key question, many decision makers in Austria or in Germany or Europe across the globe are currently facing with is how we can ensure to have the right number of people at the right time with the right skills, with the right grades, and doing the right things. Yeah? So I choose the global definition for health workforce planning by the WHO. And when you look at this definition for health workforce planning, you will hopefully agree that there's lots of challenges included. There's lots of things that have to be considered when you think about health workforce planning. And I brought one use case with me that I will show you in a minute that will give you an example. What could that mean for a practical use case? So in a nutshell, in a very, very generic, in a very simplified approach, you can see, how health workforce planning works. So you have the staff demand at the beginning, kind of prediction. This is something that is the first step. And afterwards, you have the shift planning, meaning in the first level, talking about the role level, for example, DGKB, or how many FTEs as a full-time employees you need for DGKB or assistant doctors or things like that. And the last step is putting this information on the employer level, meaning the individual level. Our current competitor, or the main competitor, because we are focusing on the first column, on the first pillar I have shown you right before, is Excel. And as we have all seen last week, dealing with Excel could be tricky. Yeah, and when you imagine that, the data we are dealing with is not big data, as I said, but it's more than 600 lines and rows. Yeah. So that's the reason why, there's many potential for improvement. Once again, what happened last week is quite useful for us currently in the sales process. So what can AI do? And I just brought some areas where currently lots of things are going on in this health workforce planning issue because it's so relevant currently for so many people. You just see an overview. I cannot go into the details, but you see that there are lots of different topics, different steps that can be considered using AI and to bring value to the customer or to the health professionals. What I brought with me today is a very specific use case where I can tell you, and I will show you afterwards in a minute, the people working with this tool or are benefiting from the results are really quite happy about it. They really appreciate the value that we can bring by using our models to their daily work life. So stable duty or shift plan means that, in the healthcare system, I mean, everybody in this room who is working in the system probably knows that it's really, really hard to keep the shift plan stable. It's even in times when you are running out of health professionals, so you have too less people around. This means that, the people who still stay in the organization, that they have often to jump in, that they have to do lots of overtime hours, that they feel very stressed and things like that. And beside that, for the managers, for the leading nurses, for example, or for everyone who is responsible for a team, there's really a significant administrative workload. For example, to get people in the morning for the rest of the day because someone has dropped off or suffered from some illness, something like that. So in a nutshell, it's really a huge problem currently to keep a stable shift plan, and vice versa. We know from many studies around the globe that if you could tackle this problem, this would be a significant countermeasure to attract working conditions for health professionals. So what we did is, or what we are doing, is that we, first of all, we link the demand prediction with the shift scheduling. This means that we start with, with the data that I've shown you before, that we try to do the best patient demand forecast, considering many different variables, many different data that we can get, including quality, including patient as a number of patient admissions and things like that. Based on that, we try to do a kind of staff demand prediction, which works out pretty well, honestly, including, for example, an absent and leave management, by the way. Then we detect, okay, compared what is required and what do we have, where are the bottlenecks, where do we have the problems, and what we can do about that to overcome that. Afterwards, the final results are put into the shift plan, and finally we have this, currently real-time monitoring system, which allows, the managers as well as the health professionals to stay in time and to keep control. So this is a system, that is linked to different data sources within the hospital. And also, it's a system that is linked to the shift plan software, because there are so many shift plan software companies already out there. And this is so in a nutshell how we use our models. We have different models at the different stages that we use, depending on the questions we want to answer, depending on the data that is available or we can use. But I just want to give you this rough overview how we use AI in this context. So finally, do we bring value to the customer? Do we bring value to the health professionals? That's the only reason that matters in the end. And what we can see in practice is that we can really significantly increase the employee satisfaction by, for example, less overtime, better work-life balance, less administration, because we really automate lots of admin processes around this process I've shown before, which is really the proof for us that we are going the right direction. And of course, there are some things in addition that we have on the roadmap that we want to put in practice to improve our situation further. Finally, just an outlook into the future. Where will it go in the next years? Of course, because I mean, the second point, more and more devices are, can be connected with hospital information systems, or data is accessible from these devices for hospital information systems. We get access to this data as well. So it's all about, real-time monitoring. It's all about using the data and do different kinds of additional predictions. And I think one of the most important things is the collaborative decision-making approach. What does that mean? When we talk about a personalized or patient-centered medical treatment, this means that we talk about teams that treat the patient, not just one, and therefore, of course, resource planning has to be considered from an interdisciplinary perspective as well. For any further questions, I'm looking forward for now and afterwards after the session. Thank you.
Thank you very much. We're a little bit behind schedule, but I think we can squeeze in one or two quick questions. There is one right here in the front.
Thank you so much, Andreas. I was wondering, I was involved in a project on task shifting a while ago, and do you think that your platform could also predict with regard to what types of healthcare professionals need to be aware? Because we often say, okay, for medical doctors, we try to get nurses instead of GPs, and radiologists instead of radiographers instead of radiologists, and so on. So would that also be a possibility from your perspective?
Yes, we can already do that. So the warehouse I've mentioned, I mean, this allows you really to know what kind of processes are happening, at what time, provided by which professional role, and we are able to, as at the moment, we are able to predict what kind of competences, for example, you would need in an outpatient area for emergency surgery, for example, on the role level, including the skills, as well as the grade, as well as the quantity behind. So, I mean, of course, this is, a back and forth process currently. We have the first, larger implementations right now, and we receive lots of feedback as well. But basically, we can do this already. What you are asking for.
Thank you. I think there is one more question here.
I was just wondering if there could also be a possibility of implementing your tool not only on the staff side, but also on the patient side when it comes to, for example, general practitioners, because as far as my experience is concerned, that puts a lot of pressure onto doctors also, inpatient patients, and I think there's a huge lack of waiting time management systems.
I totally agree. I totally agree on that. I mean, I think 6 weeks ago there was the DMEA in Berlin. It's this huge healthcare IT event, and we joined this meeting for the first time, and we received really significant demand from the general practitioner side, as well as from, because in Germany you have lots of this, for example, surgery departments outside hospitals with, I don't know, 150 to 200 people. But it seems that, as you said, that there's a huge or significant demand from this side, and of course you can take this and put it in this area as well. So it's not a big deal.
Okay. Thank you. So let's thank Andreas Diensthuber once again. And then it's time for the second session of student project pitches. So without further ado, I would like to ask Ines Seidel and Magdalena Drumi to the stage, who are going to talk about their project I Stop Falls.
Hello everybody, this is Magdalena and I am Ines, and we are delighted to be a part of the iStop Falls team. Everybody in this room knows at least one person who already experienced a fall. And by fall, I'm not talking about the season. And certainly, I don't mean your tipsy friend on a Saturday night. I am referring to elderly people who are falling to the ground due to weakened control over their bodies. Global statistics have shown that 35% of the people over 65 experience a fall annually. In Austria, every second person over 80 that is treated in a hospital experiences a fall at least once a year. So at a certain point, that would be one of my parents, one of Magdalena's parents, or even one of your parents. Unfortunately, our elderly people are exposed to a high risk of suffering from complications after a fall. Complications could be a broken bone, like the hip or the shoulder, inner injuries, a stroke, or even death. In Austria alone, 1,000 people died last year, 2022, due to a fall. That's a shockingly high number. So if we take a closer look now to the hospital setting, research has shown that 60 to 80% of all the falls that happen in a hospital occur next to the bed. So, of course, there are already some state-of-the-art methods, like, for example, the bed exit sensors. Bed exit sensors were introduced to prevent a fall in that specific area around the bed. But studies have shown that they actually have no significant effect on reducing the fall rate. So, what people that are working in the hospital are doing sometimes now is they bound the patients to the bed. We call that restraining measurements. Imagine yourself for one moment, you're sick or injured in a hospital, and you're being bound to the bed at all of your forelimbs. What an horrific thought. And that is the reason why we developed iStop Falls. What is iStop Falls? How does it work? Magdalena can answer these questions for us.
Thank you, Ines. Now, I would like to invite you all to imagine a patient with dementia who had a stroke resulting in left side hemiparesis at a neurological ward in the hospital. As you can imagine, this patient is unable to remember his physical limitations due to his memory impairment, and this patient needs help to get up and go, for example, to the bathroom. Now here is where our innovative solution, iStop Falls, comes into play. Using a motion sensor, we can detect the patient's attempt getting out of the bed. The sensor then sends a signal through a server, triggering an alert message at the nurse's ward computer as well on their mobile devices. Simultaneously, a smart speaker engages the patient in conversation to distract their attention and keeps them from getting up on their own. By implementing the system, we can save valuable time for the nurses to reach the patient's room in time and prevent possible falls. To illustrate how iStop Falls could work in practice, we've prepared a short video we would like to share with you.
Hallo, brauchen Sie Hilfe?
Ich muss aufs Klo.
Magst du bitte zum Bett 3 schauen?
Eine Pflegekraft ist schon auf dem Weg zu Ihnen.
Bitte beeilen Sie sich, ich muss schon so dringend.
Wir tun unser Bestes und beeilen uns.
In the beginning, Ines gave us some figures on fall rates. Facing the demographic change, fall prevention is going to become a crucial topic in the future. Now we would like to invite you all to visit us at our booth to discuss our prototype and its potential for that future. Thank you.
Thank you very much. So please take your time afterwards to look at those projects in a little bit more detail. So the final one today is called Identify. Vanessa Wimmer and Fabian Fiedler will present that, please.
All right, so welcome to our presentation about Identify. Our team consists of my colleague Fabian Fiedler and me, Vanessa Wimmer, and we are both students at the FH St. Pölten. And throughout this time, we have developed a project called Identify. Identify is a project which aims to detect kidney stones, cysts, and tumors and provide the doctor with information whether these conditions are on the CT images or not. But first, let's talk about the current situation. So currently, kidney stones affects around 1 to 15% people worldwide, and I'm sorry. And also the occurrence rate of kidney stones is quite high. So once a person has had kidney stones, they are more likely to develop another one in the future. Kidney tumor is one of the most common cancer in the United States and the 14th most common cancer worldwide. And kidney cysts are becoming more prevalent as people age. In addition to that, we have a data lake of unused data. Medical healthcare institutes have a lot of data in the systems which are currently not used. So we have a lot of unused potential right in front of us. So what are our goals? First, we want to relieve the physicians. By enabling fast and accurate classification of the examination result, we can reduce false positives and allow the physicians to utilize the time more efficiently. Secondly, we want to reduce the time of diagnosis. With fast AI models that can analyze the examination results right after they were produced, diagnosis can be made way earlier. And lastly, we want to provide better healthcare. By reducing the time of making diagnosis and providing more accurate results, we can provide a better healthcare experience for the patients as well as for the physicians. All right, so let's finally take a deeper look into our project, and let's start with our data set. Since it is very difficult to get access to data in the healthcare sector, we used the data set from Kaggle. It contained over 12,000 CT images from different angles, from the top and from the front, and contained 4 classes: normal, cyst, tumor, and stone. In the pre-processing for the training set, we made sure that every class is equally represented. Now, let's finally take a deeper look into our model and how doctors can use it easily.
Great. So then we developed an image classification model which can detect cysts, tumors, and stones in kidneys. And as you can see for yourself, this one segment is instantaneously, and this was not sped up in any way. So if we have a closer look, a stone was detected here, and yes, quite a big one here. But this is just a demo tool. But we could also integrate this into the hospital's radiology system and then have it automatically perform in the background and only alert the physician if there's any abnormalities detected in a kidney. So with this technology, if you're coming into the hospital now because of some pain in your abdomen and have a CT scan, if there is also something wrong with your kidneys, the physician will be alerted and measurements can be taken without you even knowing that you have something. This enables our healthcare system, as it is now, to be less curative than it is now and more preventive for the future. But let's dive a little bit deeper into how the model performs. First, we used a publicly available and pre-trained model to create our classification model, because with the low amount of data that we had, this is easier to achieve good results. And as you can see for yourself, we have a really high accuracy of 99.75%, and also the Cohen's kappa confirms this, that it is not wrong in this case. And as we're in a healthcare sector, it is really important that we have a low amount of false negatives, so that the model says nothing detected, but there is actually a problem with your kidneys. This metric is the recall, and recall also tells us that the model performs really well. And also, as you can see in the table, it is really fast. But what do all these numbers from the table mean for us now? Well, with the current generation gaming PC, you can have up to 9 full scans per minute. And this is definitely faster than you put someone into the CT and out of it again. And also, not everyone has a gaming PC in a hospital, on an old generation PC from 2012, and back then it was only a mid-range computer, you can have up to 4 full scans per minute, which is, again, quite well faster than you put someone into the CT and do the CT alone. And with this, all our accessibility goals were met, which means everybody could use it now. So you don't need a big data center in the basement. It can run on any PC in a hospital, actually. And with that, all of our goals are achieved, and thank you for the interest in our project.
Thank you very much. So, as you may already have noticed, we had a little change during the break. We had those seats put up here because the final item on our agenda will be a short panel discussion about premises and promises of data-driven healthcare. And for that, I would like to hand over to Eva Turk, who's going to be in charge of that last item on our agenda. Please.
Invite the speakers and Barbara on the stage, please. No order, just I'll take the last seat that it stays. So we have for everybody? Yes. Thank you. I have the pleasure to moderate this chat. As said, my name is Eva Turk. I'm the senior researcher here at the Center for Digital Health and Social Innovation. And we thought today just to bring you all together again, and also we have been speaking about why should patients care, and having the most important person actually on board today to give us the patient perspective as well. So I would like to introduce Barbara Kalupek, who is the chairwoman of the CMT Therapeutics, and also the peer for polyneuropathy at the Dr. Schufield Medizintechnik. So Barbara, just a question for you then, listening to all of the talks today. In your opinion, like speaking about data-driven healthcare, what do you think the patients, what role do the patients play, and how can we make the best use of the data for you?
Thank you for being here. It's not my first discussion. It's not my first discussion in the role as a patient's advocate. And it often goes like, hallo, Hausverstand, common sense, yeah, something's missing here in this discussion. It's often about interdisciplinarity and very often about evidence-based and experience-based knowledge. My part, I have to bring in then. We had this presentation now, the app that helps not to fall if you are weak, if your muscles are weak. I asked myself, there is a very simple method to keep the muscles strong. It's electrotherapy. It's not much effort. It's not expensive. It's not really common knowledge now, but it's used often even in the CPU units. And I asked myself, the students or the former guards, the former doctors and therapists, do they know about this? And what in future will make sure that such simple methods are still known? I see interdisciplinarity as a major shortcoming in the healthcare system. And this is where I see a big chance for data-driven medical knowledge transfer. But it's important to stay human and to stay with the individual, you have to treat them. As the question was about giving the data, I like to give my data. I love to give my data. You can share it wherever it is, wherever you like. In my case, you see I have a disability. For other patients, it's not so easy. But I like to give my data if it is worth it. And I like to give it if I can be sure, or if I have the feeling that you got me right, that the data you gained from me is really expressing my needs or my demands.
Thank you, and I think this also then goes in line with what we have heard before, that the feedback and then how the data are actually going to be used in the projects, or well, not in the projects, but basically for the patients. How can we then have the shared decision making? So I was wondering, Tanya, maybe with regard to the patient-reported outcomes and your projects, one thing is then how can we make sure that actually this feedback loop happens? And I think Lucas, you already mentioned this a little bit as well. But then also, how do you see, if I bring it back to the technology, and how do you see the AI then collecting this part being important in the patient-reported outcomes, and how can we build on that?
Yes, thank you. I first would like to answer what you have said about the data and also the more easygoing methods that we should not lose in healthcare, maybe. I think what is really important here is that the technology should support healthcare and should enable that the healthcare providers, and this is not only physicians, but lots of other healthcare providers, have more quality time with the patient. And that's, in my opinion, the most important thing. So, and then I think we need to serve the patients best, so we have to involve them in all what we develop in a co-creation process, so that we don't develop something which no one wants to have in the end. Yeah? And that's also important. But I think lots of the things that are developed at the moment in the digital sector are very much in line with this, because like you showed, yeah, it decreases waiting times, it makes information better available, it makes better visualizations, it gives patients also arguments at hand if they want to advocate for something or if they need something. I think and that's the way it should go, in my opinion. So I think what we really need is that all the stakeholders have some kind of saying in here. And especially like when you mentioned this patient-generated data, I think it's not only the patient-generated data, but in general, patients should have access to their data, but they should have it in a well-visualized way, because we cannot expect from everyone, like we do, reading tables and dealing with this kind of data every day. But I think we need to have it very simple, yeah? And in a way that it's well built for patients to understand. And I think this is really important. And then I think we do not lose this more, maybe also the things that have been there, like the electrotherapy or what you mentioned, or the things we used to do, but we can do it better targeted. So we can have stratification and see for which patients this would be really beneficial and which patient might benefit from other methods. And this, I think, the AI can solve, yeah? And that's really important. And for this, we need all the technology. But in the end, I think it would be important that the healthcare provider spends time with the patient and has time to focus on this. Because if you have only 5 minutes, it's better to spend it maybe with discussions than to ask again about all the symptoms, which you could already have in an app, and you have a nice visualization, and the physician would see it in maybe, I don't know, 10 seconds where the problem is. Yeah? And that's where I think the journey should go into. Yeah?
Yes, and maybe apropos the journey, when kind of like when you were speaking, Lucas, with regard to having like from prevention and then to rehabilitation. I was at one point we were thinking of having the health coach, right? As the healthcare professional should be actually the health coach. So in what way then do you think that the digital solutions streamline really the patient journey from birth to that, if we can put it like this, right? And how can then the healthcare organizations then leverage this data and analytics to enhance, first of all, the patient outcomes, but then also the operational efficiency, what we looked a little bit also, and Andreas, I'm going to bring you in here, but also the resource allocation.
Yeah, I mean, I tried to convey that message in my presentation. I think there are tons of solutions out there that already help patients across the whole patient journey. The problem we still have today is that we don't have a common understanding of data, right? So, and we need to have that first. I mean, there are initiatives going out there, like the European Health Data Space. There are standards out there, like FHIR, that I think most of the institutions are already agreeing on. Once we have that, then we can really connect the dots across the landscape, right? Across the landscape of solutions that are already there. And then, you know, our government is very proud of introducing digital vaccination passport. I mean, come on, right? That's I would say pretty easy. And if they think about the next just 2 weeks before, I had a discussion with the city of Vienna, and we were talking about allergies, right? And it just caused headaches on their side. And then I basically asked, okay, why not asking the patients to provide that, right, as a first step? So that could be played into ELGA. I think, yeah, that would be possible once, again, we agree on a common understanding of data. And then it can really help from birth to death. And I think we should embrace, again, an ecosystem of solutions, right? And that will solve it, right? Competition will solve it. The market will solve it if we, again, I have to emphasize that, if we also regulate it and show that direction and show all the players out there that they have to play by the rules.
Thank you. Does anybody else have any comments on that with regard to the regulation? I don't know, Andreas. Maybe you can add on when it comes to basically your platform, right? to bring it in, and I think also with regards to, for me, it's also a question. Importing, for example, healthcare professionals from different countries, from having different types of education and so on. Of course, especially healthcare professionals, these are regulated professions. So do you see that this would be also an opportunity for your solution, if I can put it like this?
Well, so first of all, I want to emphasize that I totally agree with what Lucas said regarding, this common understanding about data, because what we see every day when we work with our clients is that, we have, I don't know, thousands of different standards. If you just, think about nursing documentation, for example, you have different classification systems within Austria, across Europe, and so on, and this is just one example. So, we need one common understanding and, of course, standards that we all put into practice so that we can use. That's the first step. And based on that, regarding to your question, yes, of course. I mean, for example, nowadays, it's quite popular to, move around the globe and to try to collect, for example, nurses from wherever. And at the end of the day, you need to know, you have to be sure if they have the competences, to treat or to work with the patient in the same at the same quality level like our nursing experts. And this is a huge chance for skill management, yeah? Where first of all you can predict what kind of skills are required, what is the skill level of a person, for example, who is interested in joining a healthcare provider here in Europe or in Austria, and is located, I don't know, in Nigeria, for example, yeah. And then you can do a kind of test, before she moves to Austria by using AI tools, yeah, training tools, for example, linked with AR, VR, training scenarios, for example. So there are many opportunities in this area in the future. But once again, I mean, I come back to what Lucas said. We have before we move on in what the metaverse can do within healthcare. Yeah, we need to find a common ground where we get started from, and this is something where I hope that we will make progress in the next years.
Thanks, Chris. You spoke that basically a lot of companies trust you with their data. But should we actually trust the big companies with our data? And why should we?
I think there's thanks for the question. There is a lot of confusion, I think, about who has access to which data. So I think security of the data is super important. Also, compliance is very important. And at the same time, making that accessible to patients is a challenge, right? How do you do this? How do you do that securely? How does everybody build a solution like that? For example, we actually do not touch customers' data. So if you put data in there, we have no interest or any dealing with that data. It's not something we process or use for anything, right? But overall, I wanted to add to the point that the globalization of people, right? We move around the globe. My healthcare data is in New Zealand, in Australia, in the US, and in various countries in Europe. And how do I get access to that data today? It's super challenging, and I don't think I can unify that anymore without solutions that use standards like FHIR, which we also support, to really build solutions that are interoperable.
Can I add to that? I think cross-border care, I think, is a specific challenge, probably also. But there are countries which have centralized electronic health records, especially in Scandinavia, where you come from. And there is, of course, lots of issues with securities. There are countries where people have it on their phones, the electronic health records. So I think what we really need is a governance model also, where all the stakeholders have a saying in the data. So I think we should not trust a big company like so, but it's more like that all the stakeholders, including the industry, should have some kind of possibility to decide together who could have access under which conditions, and not only the industry should decide, not the big companies should decide, not the patient should decide alone, but all together. And I think that would be important. And that's what we try to do also in the H2O project, to have people or all the stakeholders decide together, because we need to hear the patients. And I think what is the common standard, like what will be implemented also in the Austrian Microdata Center, is that you have some kind of secure area where after you have an approved question, an analytic question or research question, you can then work on the data, and then you take only the results of what you have proposed in the beginning. Yeah? And I think these are possibilities, and I have been this week in Boston where we discussed also models of value-based care, and there was another startup there, and they also allow a validation of algorithms, or their business model is basically that for people who want to validate the algorithm, they're allowed to run it on health data. But they don't have access to the algorithm, and they have no access to the data, and also the company that develops the algorithm has no access to the data. So I think there's lots of technical models already, but we need to agree on that, and I think there's more hesitation, and I think we have also the problem that we sometimes tend to over-regulate a bit in Europe maybe. Despite that, I fully agree that we need regulations, but we also have to see that this does not hinder and be a barrier to all kinds of developments if it's too difficult to do the things. Yeah? But on the other hand, I agree, I think regulation is important. This is a high volatile market, and we need to have all these regulations in place, because otherwise there will be lots of issues with not only data protections, but also things which are wrong maybe, or where we draw wrong conclusions. Yeah?
We heard a bit now on the co-creation part that it's really needed, and that everybody needs to have actually a stake. So Barbara, just before we finish with a final question, what would make you as patients or patient representatives really buy into kind of like using all of the technologies? You said like you love to share data. I don't know if everybody loves to share data, but more in a sense of like, what do you think that this is really kind of like the next steps for us, how to be involved?
I think it's not longer a question of buying in. We are involved. There's no way out. And some things are too regulated. If I go to Med University and I had an examination in level 4, they don't know the results at level 6. It's silly, I mean, for me. We are involved. There's no way out. I remember a workshop here at St. Pölten, and it was about teleconsultation. And I said, I like it. It's cool. I like it because the doctor is more looking in my eyes. And I like men looking in my eyes. Yeah? Not only men, women too. In the reflection round, one of the participants said, I didn't know patients want to be looked in their eyes. And I said, well, okay. It was a student. I hope she learned it. I mean, she learned it here. So this human touch, I think this is important. Patients want good diagnosis and want health system working without long time waiting for something. We want sensible treatment strategies. We want reminder texts and apps and things like that, but we want apps that also work with polyneuropathy fingers. So even if you don't feel what you touch, it should work. If it's hard to hold it or too small, it's not so good. But we still want to be treated as a human being, and I think the treatment should go to be guided to resilience and self-efficacy. And if we talk here about platforms as a Selbsthilfevertreter, as somebody who is in a group too, CMT Austria, I would like to share data and get data from your platform too. And I want to have the pictures for my new folder. So I would like to have entrance in these platforms too.
Thank you so much, Barbara. And just to finish off, because we also heard a lot from the patients and really great ideas, and we are at the University of Applied Sciences. So from your perspectives, then, what do we need to teach our students? You just mentioned kind of like it's important to look in the eye, right? but also what kind of skills do you think we will need then in the future? And it goes a little bit to the question that Jakob asked before, you know, how can we then combine the clinical, the technical, the social and health aspects? So I'll just start with you, and then maybe everybody can have a final statement.
Well, I would say teach more philosophy. And the reason why is because we always need to question things, right? Do we need that? Do we need a technological solution for that, or can it be done the old way, right? Not in a good manner. And also, talking about large language models, right? So I will leave that for later, but we need to question things as human beings, right? I think the more complex our society and our, the world becomes, it will be more and more important to question things critically.
Well, I would say that what matters most is that you put your client or the customer into the middle, so that you really focus on what does the person really need, what really brings value to the customer, what really aligns with the processes, how they work. I mean, there's so many bad software out there within healthcare which forces people to change their behavior or in a bad way. Yeah? And I think this is something that needs lots of people like sitting here in the audience to change the situation. So this is something I would say finally.
Yeah, what big American universities do, like Harvard and others, they build houses and departments in the middle of, and in the connection between medicine and healthcare and health services and technology. And I think that's important. That's where the future will be in medicine. And I think we will not lose the human component, because that will be always an important aspect, like you said, in medicine and in all kinds of health professions. And maybe it's important to have these ethics things as well. Yeah? But I think this interface between healthcare, health science, medicine and technology will be the future. And that's, I think, was a very wise decision here at the University of Applied Science, and especially Jakob, I think you have done a lot of work there. I think that's very good and very important, and we will in the future have more of this interdisciplinarity and not that much the silos in the professions that we had before. And I think that's where the future is, and where we need to educate more. We need more people who are hybrids, yeah, who come from health professions and do data science or develop something, or vice versa. And I think this will be really important. We have all these different people working together, because then we can be really innovative. And I think we need also the people from ethics, from the social science, to help us and guide us about what we should do, maybe. Yeah.
Yeah, I couldn't agree more. Interdisciplinarity, I think, is a very, very important aspect here, where we bring technology and the healthcare industry together. So I remember my part of my studies was an applied subject, and since we had applied university, I think that's really interesting opportunity you have to teach how it really works in healthcare today, right? And what are the problems? Understand the business and understand the problems that exist, so you can help them solve them. I think that's the opportunity you have here.
You were right before to say I'm not a typical patient for everybody. There are many diseases people don't want to be known. They are like depression, even diabetes is people don't want to know their employer. But there I have more a problem with being at the local doctor, and he says, "Ja, sowieso, bitte aufschreiben, wollen Sie ein Rezept für da, da, da?" Yeah, so just calling the names and talking loud in a room full of people in a little village. I am afraid of my data there more than in the World Wide Web. But I know it's gained money with this data. Your question now was about training, about the students. It is a fact that lack of time, excessive demands, exploding scientific news are major shortcomings in the healthcare system at the moment. Artificial intelligence can bring a lot of benefits to arrive at a picture and a decision faster. But as we heard in one of the presentations, to make a good decision, it's not possible to talk if you are anxious, if you're under pressure, if your judgment is impaired by fear or stress. So there is absolutely a need to have good schedules, but there is also a need to have just enough staff and to have people who can come and support the team if there is a lack for too long. But for this special decision making in the minute of stress, in the minute of life or death, or just do it right or do it wrong, I think it's important to teach philosophy too, and to teach how the ability to reflect, to be present in the moment with all the senses. And I said before, I like teleconsultation because this look in my eyes, but there is missing that somebody is looking at my feet, and if you don't look at my feet, you won't really know what's wrong with me. So it's a bit to learn to walk in somebody else's shoes, just to what does it feel like and what's the need then, and then set the right activities.
Thank you so much. Thank you, everybody. I know that we took a little bit more time than was foreseen, and I know that some senses are getting, yeah, I'll just leave it like this. So thank you so much for the great panel, and I'll ask Florian then to come back and finish off.
Thanks, everybody, for this panel. I think that was a very nice conclusion of the day. I personally have the feeling that I really learned a lot today, so I think it was a great event. Let's all give a big round of applause to the organizers, to Jakob Doppler and all his team, and everybody who helped putting this together. All right, okay, so we heard about so many different aspects today that I cannot really find this one or two sentences putting everything together, wrapping everything up, but maybe this is not really necessary anyway. It was a day about data-driven healthcare, and I think a lot of data was dumped into your brains today, but we learned during all those sessions that having data is not enough. It's all about how to process the data, how to connect the data, how to work with the data, how to make good decisions using the data, and that is, of course, now up to all of us. That's what we have to do now with everything that we learned today. And in order to connect data and draw the right conclusions, of course, the first step very often is connecting people, and that's also what we are here for today. So please do use this opportunity. Don't rush home right away, but maybe take a little bit of time outside. I've been told there is ice cream. So sorry to everybody who's just watching us on video. No ice cream for you today, so this may be an incentive to come here in person next time. And everybody else would very much appreciate it if you stick around a little bit and talk to each other, and maybe we could connect our ideas, our thoughts, and our impressions, and aid to the success of the whole story. So thanks everybody for coming here. Thanks all the speakers for their input, and See you again next year at Build Well-Being 2024.